I think you have to start back with diffuse large B-cell lymphoma at its diagnosis. We treat diffuse large B-cell lymphoma in the majority of cases with curative intent, which means that the goal of the initial line of therapy is to take this lymphoma away and never have it come back. In 2018, we continued to use an R chemotherapy-based induction strategy for those who can get curative intent therapy. R-CHOP is, I believe, the standard of care. It has been challenged in multiple clinical trials in a randomized fashion, and at least in the United States, that continues to be the frontline therapy. So in those patients who have advanced stage disease that get 6 cycles of R-CHOP, we do about a 50% chance that we have a long-term disease-free survival or cure those patients. Now, the other 50% is what we're talking about here today, which becomes in that relapse refractory diffuse large B-cell lymphoma standpoint. And I think when that occurs, so relapse that is confirmed by a biopsy that shows, once again, diffuse large B-cell lymphoma, I think it really matters. The first question that you have to ask yourself is, could I potentially transplant this patient? And if that answer is yes, and they fall into the transplant eligible category, then I believe the standard of care is second-line, high-intensity therapy with the intent to consolidate with high-dose therapy and autologous stem cell rescue, or other people call that autologous stem cell transplant. Now, in those patients who are transplant ineligible, that becomes a population that I think that the goals of care change, and those goals of care become to keep their disease under control for as long as possible, and really think about quality of life as a premium. And so, in that case, we may change the intensity of our therapies and choose different things than we would in the intensive therapy or the transplant eligible arm. Speaking to directly the transplant eligible arm, second-line therapies like RICE or DHAP or GDP, with or without rituximab containing regimens, depending upon whether or not they were coming off of R-CHOP chemotherapy and were refractory to frontline therapy, or had a sizable remission duration. Those response rates are well within the kind of the 60% range. Now, I think it's very important that there's data that shows that potentially being in a PET negative remission at that time point may help with long-term improvement post an autologous transplant. And kind of those people in a partial remission, you really have to look at and how good is that partial remission, and maybe consider other strategies that you would want to do, considering radiation after transplant, if it's a localized focused area, versus other options to try and get a third-line therapy, try and potentially improve their remission prior to going to transplant. So speaking towards the transplant eligible spectrum, RICE, RDHAP, RGDP have all been studied. Now, in the CORAL study, the RDHAP versus RICE study was performed, showing equivalence. And then also in a Canadian study, the RGDP versus the RDHAP study showed equivalence. So really, you can't compare RICE to RGDP, but if you kind of play some fancy arrow drawing, you could argue that all 3 of those chemotherapy regimens are probably equivalent in the second-line setting. Now, the important thing is that those patients achieve a very good remission prior to going into a high-dose therapy autologous stem cell rescue or auto transplant to hope for long-term disease control or a second chance at cure for many of those patients. Now, unfortunately, probably half of those patients will not achieve a long-term disease-free state and will once again have their diffuse large B-cell lymphoma come back. I should mention that there is a population that is probably at higher risk when their disease recurs, and those are people who relapse very quickly, or those individuals who never have a disease remission at all. And so that's a whole category that when we're thinking about taking them through second-line therapy and potentially a transplant, I think we have to be very cautious and be looking to see and making sure that they're truly responding to second-line therapy. If they're not, then they probably should not go towards a consolidative transplant.